Thanks for the invitation to come speak to you today. So I'll be following up where Mike Yin left off, taking a more clinical view, talking about falls and fractures in people with HIV and how to prevent and treat them. Here are my disclosures. So when we look over the lifespan, we see a decrease in both physical and cognitive function that generally declines over time. And we often model this as sort of a steady decline over time, but in actuality, it's precipitated by events. And so someone in their 50s, for example, has a heart attack. They don't quite recover after the heart attack. Their function decreases. They have another event like pneumonia, a big event like a hip fracture, another big event like a stroke, and then they become disabled on into their later life. So obviously hip fracture is really important. All fractures are important. And we know that fractures increase with increasing age. This is from the general population where fractures increase dramatically after age 65 in women and after about age 70 in men, which not only leads to problems with function and morbidity, but also mortality. So the question comes, how can we prevent fractures in people living with HIV? So some of this may have to do with antiretroviral therapy management. And so as Mike told you, we want to avoid TDF and PIs in people with a high fracture risk. The other important aspect is appropriate screening, as Mike also alluded to. So in people living with HIV, men 50 and older and all postmenopausal women should be screened if possible. The caveat here is that DEXA screening only explains about half of fracture risk. So it's good at measuring bone mass, but not so good at measuring other aspects of bone like bone quality, or of course, it doesn't measure fall risk at all. The other thing that we want to do is to identify appropriate candidates for treatment. So according to the US National Osteoporosis Foundation, these are the guidelines about who we should treat. So those who have a hip or vertebral fracture, those who have a T-score in the osteoporotic range, and then for people who are in the osteopenia range, that is between a T-score of -1 and -2.5, and they have a 10-year hip fracture risk of 3% or greater, or a major osteoporotic fracture 20% or greater, they also should be treated. And this is using the FRAX model, which most of you are familiar with. So if you log on to the computer and look at the FRAX website, you come up in this website in Sheffield, England, you find your country and you put in your patient's information and press calculate, you get a 10-year risk of their fracture. And this can be used either with or without bone mineral density. The caveat here is that FRAX generally underestimates fracture risk in people living with HIV. So there's concern here that it may not be telling us the whole story, and it leads to the question whether treatment thresholds should be any different in people living with HIV. Should we be treating with a fracture risk that is lower based on FRAX? In clinic, a very useful tool to further risk stratify is a plain spine x-ray. And this is a cohort in Italy, unselected cohort, people coming into clinic, and they got radiographs of the thoracic and vertebral spine. And what you see is about 15% of these people had fractures of their spine that were completely clinically silent. And what's notable here is most of these actually happen in people without osteoporosis, that in these columns on the right here, the ones that are orange and red. So what this tells us is that the DEXA really isn't telling us everything we want to know about bone mineral density, and spine x-rays are a cheap and effective way of further risk stratifying. So once you've decided about the person should be treated, what treatment should be given? So you have many choices here. First, there are some general recommendations. Calcium, about 1,200 milligrams should be given daily preferably from the diet. There are some lingering concerns, although controversial, about calcium supplementation and cardiovascular disease, but which is not present with dietary calcium intake. Vitamin D supplementation, so getting to 800 international units of vitamin D daily, or you can target their 25-hydroxy vitamin D to get it up above 20 nanograms per mil, or above 30. And this also improves the efficacy, at least BMD efficacy, of bone-specific treatment, getting the vitamin D level higher. Smoking cessation should be encouraged, alcohol reduction, weight-bearing exercise, and a review of the medication list to discontinue any medications that are associated with osteoporosis that can be changed to something else, corticosteroids, thiazolidinediones for diabetes, or proton pump inhibitors, and several others. So pharmacologic therapies for osteoporosis can be broken into two categories, antiresorptive and anabolic. On the antiresorptive side, these are osteoclast-directed therapies, including bisphosphonates, selective estrogen receptor modulators like raloxifene, denosumab, and hormone replacement therapy. For anabolic therapies, these are osteoblast-directed. These include PTH and PTHrP analogs, teriparatide and abaloparatide, respectively, and then the newest agent, romosozumab. So bisphosphonates are generally considered the first-line therapy for all patients with osteoporosis who don't have a contraindication. In the general population, we know that they reduce vertebral and non-vertebral fractures to 25 to 50%. In people living with HIV, there have been no fracture trials. Of course, these are big, expensive trials, but the BMD trials that have been done have shown a efficacy at increasing BMD about the same as you would expect in the general population. So one question that comes up is whether they should be given orally like alendronate weekly or IV like zoledronic acid yearly. So on the oral bisphosphonates, they're generally lower cost. Most of them are generic, but they are associated with gastrointestinal problems. Importantly, they have poor bioavailability. The absorption across the gut is less than 1%. And there is poor compliance and persistence, such that about 50% of people who should be on these drugs a year later after prescription are actually continuing to take these drugs. On the IV side, they are clinic administered, so this adds to increased cost. In about 20 to 30% of patients, they get an acute phase reaction, which is similar to a febrile flu-like illness, which lasts about 2 to 3 days. It can be reduced with giving acetaminophen or ibuprofen at the time of the infusion, but it makes it particularly tricky in pandemic times, and patients need to be warned about this. Hypocalcemia can be a problem. And importantly, I think a real advantage is that you get over the bioavailability and adherence problems in that it really is directly observed therapy. Personally, I've been moving more of my patients towards yearly zoledronic acid. There are some long-term adverse events of antiresorptives, particularly bisphosphonates. And this has to do with their long-term effects on bone turnover. The first of these is osteonecrosis of the jaw, so death of the jawbone. And the second is atypical femoral fractures. So most fractures occur either in the greater trochanter and the femoral neck. These are generally mid-shaft, and have to do with suppression of bone turnover, but fortunately are really very rare. The issue is that the worry of these very rare adverse events has taken a toll on the number of people being prescribed bisphosphonates, and people who should be getting the drugs are not getting the drugs. And you can see this very nicely in this claims database looking at the prevalence of bisphosphonate use from a period of 96 to 2012. And you can see that after these reports of ONJ and atypical fractures came out, you see a precipitous drop in the prescription rate of bisphosphonates. And many of those people who aren't getting bisphosphonates could benefit from them clinically. So this is brought up the idea of a holiday after a certain period of time on these potent antiresorptives. And so after 5 years of alendronate or 3 years of zoledronic acid, reconsideration of their use should be done. For people who have multiple fractures or have very low bone density, generally considered less than -3 or so, the drug should probably be continued because the benefits outweigh the risks. There are a lot of questions about drug holidays. If you do them, how long should they be? How do you monitor during drug holidays? After the drug holiday, do you put them back on bisphosphonates or you give them something else? And unfortunately, none of these questions has been adequately answered. There's some interesting data that just came out in the past month looking at fragility fractures versus atypical femoral fractures in a Kaiser database in Southern California. Here they were trying to get an idea on the left about how many fractures would be prevented given a certain number of atypical femoral fractures. And if you look at the 5-year timeline, and this is where they had most of their data, you can see that for the 8 femoral fractures, atypical femoral fractures that actually happened, you'd be preventing 859 clinical fractures and 286 hip fractures. So when you're weighing benefits and risks, there really is no comparison, assuming that you're giving these drugs to the population that should be getting them. The other important piece of information that came from this paper is the precipitous drop in the risk of atypical femoral fractures after discontinuing bisphosphonates. So this is months since discontinuation of bisphosphonates. Here you see that after about 15 months off of bisphosphonates, the risk of atypical femoral fractures goes back down to baseline, which provides evidence to support this idea of a drug holiday. So let's talk about some of the other medications. So here's denosumab, which is another very potent antiresorptive. So you see on the left, osteoclasts and osteoblasts, they communicate through the rank ligand system where rank ligand binds to rank that's on the osteoclast and activates it. And the denosumab here in blue intercepts the rank ligand so that it can't bind, so the osteoclasts are not activated. So it has a potent effect on osteoclast activation, increasing bone mineral density, decreasing fracture risk. The issue is that the rank ligand system is also used by immune cells to communicate. And one of the side effects is a risk of infection, which is relatively rare, but it's important to think about in immune-compromised populations. So I use it very judiciously in people with HIV and try to avoid it in those with a persistently low CD4 cell count. There's really very little data in people living with HIV, so I use them cautiously. It's given every 6 months. And one of the issues with denosumab is that the bone turnover, which is very tightly suppressed, comes back even above baseline at the end of the dosing interval. And this period after the dosing interval is associated with an increased risk of vertebral fractures. And so the medication should be given a long time, or at the end of the dosing interval, you should follow up with bisphosphonates so you don't get that rebound in bone turnover. Importantly, while bisphosphonates can't be given to people with a GFR less than 35, denosumab can be given, but however, there's some issues with hypocalcemia in this population, so they need to be given cautiously. On the anabolic side, PTH and PTHRP analogs are important therapeutics. They are generally given after bisphosphonate failure. In people who have severe osteoporosis, they can be given first line. And there's some question whether they should be given first line anyway and then be followed by resorptives versus the other way around. This is a study on the left that looks at patients getting treated with either teriparatide or alendronate with glucocorticoid-induced osteoporosis. And what you can see is the bone mineral density gain that you get with teriparatide is much greater than that which you get with alendronate. They're only given for 18 to 24 months, and you need to follow them with an antiresorptive or you lose the gains in bone mineral density obtained while on therapy. It's given by the patient as a daily subcutaneous injection. The newest drug available is romosozumab, and this is another anabolic that's a monoclonal antibody to sclerostin. So if you recall, the osteocytes are in the bone matrix here in purple, and they release sclerostin, which communicates with the osteoblasts to decrease osteoblast activity. So what the monoclonal antibody does is release the brakes on the osteoblast so that it can make bone. At the same time, it decreases osteoclast function. And so they're generally given for a year as monthly injections. In the head-to-head trials, there were greater bone mineral density gains compared to alendronate or compared to teriparatide. And there's greater fracture risk reduction compared to alendronate in a clinical trial. Right now, they're reserved for people with severe osteoporosis or those who have intolerance to other osteoporosis medications. Let's shift gears and talking about falls, because these are really quite important and it's really important to prevent them. So people with HIV have multiple risk factors for falls, such as sedative use and other medications that may precipitate falls, cognitive or visual impairment, lower extremity disability, such as neuropathy, muscle weakness, and frailty are all really important contributors to falls. So what can we do to prevent falls? So first of all, you need to identify a faller. And I generally ask this question in clinic: are you worried about falling? Because this identifies a patient who is at higher risk of falling. And then you can intervene with a physical therapy assessment and treatment program to improve strength and balance. And there are other factors that can be assessed and modified as well. Environmental factors, instructing patients to keep bathroom lights on, avoiding loose rugs, and removing clutter and keeping wires behind the furniture. All of these things that can be associated with trips and falls. Behavioral assessment is really important in making modifications, having the patient avoid excess alcohol and drugs, consider deprescribing for medications that may be associated with falls, having the patient wear sturdy shoes, and avoiding slippery and uneven surfaces. All of these are critical. So in conclusion, fractures are likely to be a major source of morbidity for aging people with HIV. In general, DEXA screening should be more aggressive in people living with HIV compared to the general population, given the high fracture risk. Bisphosphonates should be considered first-line therapy in people living with HIV. And adherence to treatment is a major challenge. There are a lot of questions that remain regarding the optimal duration of treatment and sequencing of medications, and really fall prevention is key to prevent fractures. So in HIV, we're used to thinking about the HIV treatment cascade, where at each step between identifying people with HIV and linking them to care and retaining them to care and getting them antiretroviral therapy, there's a drop-off, and there are opportunities to improve care and to increase the number of people who have a suppressed viral load. Similarly, with osteoporosis, we have these gaps as well, but they're not well defined. We have a population that are at high fracture risk. They need to be identified through appropriate screening. They need to be prescribed specific treatment, and they need to be adherent to this specific treatment. Now, I've made up these numbers completely, but just for illustrative purposes, it's important to really find out where these gaps in treatment are and if they differ in people living with HIV compared to the general population. And only in this way can we identify what needs to be done to better prevent fractures in people living with HIV. So if you look at the guy that I presented to you before, if we can eliminate hip fracture, as well as some of these other comorbidities, if we can prevent this hip fracture from happening, we can bend this curve upwards and improve health span and lifespan in our patients. Thanks.